So Kelly asked me to do this talk, and my first thought when she asked me to do this talk was, why would she want a clown like me to give this talk? Yes, that is me. That was me at Halloween. My 20-year-old daughter actually did that makeup job, which was pretty outstanding. So anyway, why me? I have no idea. But she picked me, so I'm happy to do it. Here we are. And if anybody has any questions along the way, just stop. I'm happy to have you interrupt. Okay? This is about being professional in the operating room. So, why be professional? Well, does anybody know who George Carlin is, or am I too old for everybody in this room?
I know.
Okay, all right. Always refer to George Carlin for philosophy, right? Recently went to a new doctor and noticed he was located in something called the professional building, and he felt better right away. So, a little bit of humor, but obviously professional does mean something, at least the term. But no, really, why would we want to be professional? Well, the Accreditation Council for Graduate Medical Education, which is what we as physicians go through when we're in residency to become accredited, mandated that all residencies in all disciplines must teach 6 competencies, and the first one they listed was professionalism. This is in the order that they listed them. Some of these are a little bit hard to define, and professionalism is a little hard to define, as we'll get to in a little bit, but professionalism, patient care, medical knowledge, practice-based learning and improvement, systems-based practice, and interpersonal skills. Those are the 6 things that they really want residencies to hit on with their trainees. And I'm sure you can appreciate that a physician needs to be pretty good in all of those things. And some are better at some than others, but professionalism tops the list. So that's pretty impressive, I thought, pretty important. So what does it mean to be a professional, or to be professional? You know, this is the dictionary definition of what it means: showing a high degree of skill or competence, or somebody whose occupation requires extensive education or specialized training. That's one definition of professional, pretty broad definition, not just in medicine. Here's professionalism defined by the American College of Surgeons. Again, I'm talking about for physicians. A declaration of a way of life in which expert knowledge is used not primarily for personal gain, but for the benefit of those who need the knowledge. So that's kind of getting to helping others, isn't it? Which is one of the things that we do in medicine. This is a little bit more targeted for nursing. This is how it's defined for nursing, something I found, a couple of good quotes I thought. Professionals are expected to demonstrate a certain degree of altruism, special attainment, self-sacrifice, and the right attitude in their dealings. Another good definition that I found: working with a team of healthcare professionals to provide care for patients in need requires a discipline and internal and external composure that stays steady throughout the day. So there's a lot of pearls in those sentences, I think. Special attainment, altruism, self-sacrifice, right attitude, those are very important things if you're going to be professional in an operating room. It's really about character traits. It's kind of hard to teach that sort of thing, but it's something that you can get better at if you focus on the right things. And what it says in the second one there about staying steady throughout the day, that's a really important thing, I think, too, because every day is different in the operating room. Personnel are different, cases are different. Some days, great, blow right through. Some days, very challenging. Some cases, very challenging. And a real, true professional is going to stay steady throughout the day, regardless of the caseload or regardless of the type of case. This was something else I found that I thought was interesting. This is a quote from somebody who had written a publication called Letters to a Young Doctor. This was dated a little bit, 1982, but that's not that long before I trained. So, at this, the start of your surgical internship, it is well that you be told how to behave in an operating room. You've scrubbed your hands and been helped into your gown and gloves. Now stand out of the way. The first rule of conversation in the operating room is silence. That's a little harsh, but it's also not a bad place to start. You don't want to pop into an operating room and suddenly be blabbering all the time about this or that or the other thing. There may be some times when that's appropriate, but there may be some times when it's not. How many of you all have done any time in an operating room yet?
other than
Just
observations?
Well, no, that's what, including observations. Have you all done that yet?
Yeah.
You've all observed, okay. Have you done any work at all yet in the operating room?
Next person has not.
Okay. It can be kind of a somber place, but it can also be a fun place. You really kind of have to learn to gauge the mood and gauge the temper of the people in it, and we'll get to that here in a little bit. But as a rule, it's always best to just kind of start out making sure you're not in anybody's way. As you know, in an operating room, there's a lot of things that are sterile, and there's a lot of things that aren't. Of course, you all know about the rules on those, but it's best to just make sure you're standing back from those things that might be sterile. You don't want to contaminate anything. And you also don't want to interrupt anybody or say something that might be construed as inappropriate. So it's best to just be a little bit sedate to begin with. Talking and behavior in the operating room is kind of what this is all about. I've broken this up into really 3 categories, I guess you could say. First is to follow the lead of the surgeon. As we'll talk about here in a little bit, the surgeon is the captain. Secondly, you want to always respect the patient. It's all about the patient. It's not about the doctor, it's not about the nurse, it's about the patient. And lastly, tied into that, patient safety always comes first.
I think I've heard that before.
That's what matters more than anything. And if you ever lose sight of that in an operating room, you've lost sight of the main goal. Because everybody in there is there to help the patient, period. It's not to stroke anybody's ego. It's not to win brownie points. It's not to pull a paycheck, even though I know that we all need that. It's really about helping the patient. That's one of the beauties of medicine as a discipline. Whatever part of medicine you're in, you're really there to help people. And that, at the end of the day, is what's going to make you feel good about yourself and your job. Every surgeon is different. Some surgeons like to talk, some surgeons like it quiet. There's an older surgeon, he's not a surgeon anymore, but Dr. Campbell, who works for me, he used to be an eye surgeon. He has a sign that he still has hanging on his little door that says, "Quiet, please, eye surgery in progress." I know from his personality, he's probably somebody who didn't want any talking in his operating room. To me, that doesn't bother me. But everybody's different. And you need to kind of gauge that. And that's what I mean by it's always best to kind of start out being a little humble, being a little quiet. Don't just jump in saying a bunch of stuff right off the bat, because you don't know how that's going to rub that surgeon. And again, it's not that you're just trying to please that person, but that surgeon, he or she is the captain of the ship. That doesn't mean that the surgeon is more important. The surgeon is no more important than anybody else in that operating room. But the surgeon is the one ultimately responsible. And we as surgeons don't take that lightly. We bear a lot of responsibility for that patient, and things that other people do or even say in that operating room are ultimately our responsibility. And so you want to defer to whatever the demeanor of that patient is, or I'm sorry, that surgeon is, for how your behavior is and how your conversation is in the operating room. As I said, some do like conversation, some don't. It may depend for some on how the case is going or what type of case it is. You know, that's going to vary perhaps from case to case or from day to day for even the same surgeon. And that's something you'll get a feel for. I mean, some of the scrubs I've worked with, they know when something maybe isn't going quite right for me, and they'll learn to clam up and maybe not ask me quite as many questions about how my day was yesterday or whatever if things aren't quite going as smoothly as I would choose. And then as far as how you refer to the doctor, it's best always to assume to refer to them as doctor or doctor such and such, unless you're told otherwise. I don't really care what people call me. People call me Dr. Frame. I don't really care if they call me by my first name. I know Dr. McCall likes to be called Rod by a lot of people he works with, but there are other doctors that want to go by doctor and are offended if they're not referred to as that. So it's always best to assume that. You know, I grew up in Anderson County, and a lot of my people that I know down there call me Kenny, because that's what I was when I was a kid, and I don't care. You can call me that. Patients can call me that all they want. But you have to be from Anderson County to call me Kenny. I'm just going to point that out.
Duly noted.
Patient awareness. For my patients, the vast majority of my patients as an eye surgeon are awake but sedated for their surgeries. Not always. We do some general anesthetics with an ET tube for things like strabismus surgery or a really complex plastics case. Many times for a plastics case, we'll have a continuous IV propofol drip and an LMA managing the airway, so those patients will be out. But a lot of my patients are awake, so most of the time people know to be careful what they say in the operating room because the patient will hear it. But always be aware that there's anesthesia, and then there's analgesia, and then there's amnesia. Those are three different things. Anesthesia is a general term that really just refers to the overall sedation and pain control of a patient. Analgesia is specific for pain control of the patient. And not all anesthetic provides analgesia. And most importantly for this talk, amnesia is separate from both of those things. Amnesia means a loss of memory by the patient. And there are some anesthetics that provide amnestic effects, and some that don't. And there are, I'm sure you've probably heard stories of patients who were asleep, but remember things from during their case, and remember things that were said, remember maybe some disparaging things that were said about them by somebody in the operating room and are offended. So you have to be careful about that. You can't always assume that an asleep patient is not going to hear what you're saying. So for that reason, and for many other reasons, we should never disparage a patient. As tempting as it might be to make some offhand comment about a 350-pound patient who's there for some health reason that's directly related to their obesity, it's not appropriate, even if they're asleep. It really isn't. And it's also something, be careful of comments or exclamations or questions that you ask. Even questions, even benign seeming questions have been a problem for me in the operating room, stemming from scrubs sometimes. For instance, you don't want to say something like, oh my God, doctor, was that supposed to happen? No patient wants to hear that. Or saying, oh no, or oops, I didn't mean to do that. I mean, these are kind of obvious things, but that's part of professionalism. You have to turn off that sort of thing when you're in this format. You can't say something that's going to be interpreted or maybe misinterpreted by the patient as there being a problem. And I've had, for instance, during an eye case, during a cataract case, if I'm doing something a little bit differently, I've had it asked of me of a scrub before, during the case, ask me, now why are you doing that? I haven't seen you do that before. Well, imagine if you're a patient and you're under a drape and somebody's got instruments in your eye and you hear a scrub say that. I wouldn't like that. I'd think, holy crap, something's wrong. This scrub's never seen him do this before. I would want to hear that. So for me, and I think most surgeons would probably agree with this, it's best to reserve a question like that, particularly for an awake but sedated patient, until after the case. Make a mental note to yourself and say, I'm going to ask the doctor about that afterwards. I'm not sure why he did it that way. Or I'm not sure what he was doing because I've never seen him do that. But be careful what you say when a patient, especially when the patient is obviously awake, because you want to alarm them. You don't want to generate unnecessary questions for the surgeon either after the case or the next day from the family or whatever. Just be aware of little innocent seeming things like that. Perfectly good questions. The timing is appropriate. The timing is critical.
Do you think that most surgeons appreciate when you ask them questions like that and do understand it?
Excellent question, and once again, every surgeon is different. I love questions like that. And I'll tell you why, because number one, it tells me that the scrub is paying attention, that they know that that was something different than usual. And number two, well, there's really three reasons. Number two reason, because I like to teach. Number three reason is because the best way to learn is to understand. If you're learning just by memorization, it's not going to stick very well. And you're not going to be able to extrapolate that knowledge into a slightly different situation like we all have to do in life. But if you're learning by understanding, and you understand why the surgeon is doing this step first, and this step second, and this step third, and then you're like, why would he want to do that before that? And then maybe you get to the place where you say, you ordinarily do this, because you're pretty comfortable knowing that it should be, and I as a surgeon am appreciative of that. Not every surgeon is going to feel that way. And that's what I mean by getting to know your surgeon. There are some surgeons that, unfortunately, might take offense to a question that they may feel is directed at them doing something out of order or whatever. But for me, and I think for most surgeons at this hospital here anyway, I think that questions are good. But you want to time them right, particularly with regard to what the patient's going to hear in the question. Patients come first, as I mentioned earlier. If you remember one thing from this lecture, I know you heard this before, I'm sure Kelly's drilled into your head already. Patients come first. And if the patient is not coming first in that operating room, there's a problem. Either with the surgeon or with somebody else who's directing them in a different direction. The patient needs to always be the priority. Everybody in that operating room can be a patient advocate. You don't have to be the surgeon or the circulating RN or the scrub necessarily, or anybody in particular. Everybody in an operating room can be a patient advocate, can be looking out for the best interest of the patient. And keep in mind that you as a surgical scrub are a vital part of the team. Don't ever let yourself think that you're less important, as I said in that on that earlier slide. Everybody's role is important. Everybody's role is vital. You know, in my operating room, everybody plays a role in the timeout. Everybody plays a role in the care of the patient. And making sure that we're doing everything right, and observing. Because you might be the one who happens to observe something that nobody else happened to see. Never withhold information for fear of offending someone. I'll tell you a little story. This was many years ago. This was back when Sam was our nurse anesthetist there. And I think it was, I don't remember who my scrub was. Anyway, I did a strabismus case, floated along, did it like I ordinarily would do a case. After the case was completely over, Sam came to me and said, "Do you know what you did during that case?" I said, "No." He said, "You took one of the sterile cotton evaporators, pushed your glasses up, and then you used it." I'm like, "Oh, why didn't you tell me?" I mean, I'm not above making mistakes. Nobody's above making mistakes. And if you see something like that, you should say something. Even if it's already happened, you should say it, "Doctor, you're aware of what just happened." Again, you don't want to alarm the patient, but in this case, the patient was asleep. And if you see something like that, it's your duty to the patient to say something. Now, fortunately, that patient was fine. I'm lucky as an eye surgeon. There's so much vasculature around the eyelids and the eyeballs and stuff that infections are really quite unlikely. It's not like operating on feet. But, you know, things like that are going to happen. And everybody makes mistakes, and that's part of the reason why, you know, in my cases, when we're checking things, we have a series of actions that have to be done before the lens implant itself, for instance, is open. I have to check it. The circulator has to check it. The scrub checks it up against the board. That's 3 people. All 3 people would have to make a mistake for there to be a wrong lens implant put in. Same thing occurs with regard to the operative site. I check the site. I check the site with my pre-op orders in the holding area in the anesthesia. I check the site in the operating room with my chart, with my paper chart, and with my EMR on my iPad. I have other people checking that too. So redundancy built into a system is exactly what you want, and you're part of that. You are part of that system, and it's partly your job to make sure that things don't get overlooked or things don't get missed, or that something that happened that was a little bit inappropriate. Maybe somebody leaned over a drape and shouldn't have, or you know, wasn't sterile. Things like that are things you can catch, that somebody else might not be the one that sees it. Many times, you know, we'll prep the eye, and I'll be turning, and I'll be downing and gloving, and the patient they've got some Versed on board, they'll reach up, touch their eye. And if nobody's watching that, you know, if the nurse anesthetist happens to have their back turned, it might be the scrub that's the only person that happens to see that. You see it, you save that patient from having a contaminated surgical field, but maybe save them from bad eye infection. So you're part of that team. Don't ever lessen your importance as a role in that. You're just as important as everybody else for that. Never withhold that information for fear that you're going to upset a surgeon. Any surgeon that's worth his salt is going to be grateful to you for saying something like that. Okay? So, do you think there's a place for humor in the operating room? What do you think?
Tasteful humor, maybe,
Tasteful.
depending on the team that's in there.
My answer to that is absolutely. There's definitely a place for humor in the operating room. You know, tasteful is a good way of putting it. That doesn't mean that you're cutting up all day or it's just all a big joke. That's clearly not it. But there are many times when we all get to laughing in the operating room. And it's, of course, never at the expense of anyone. Just funny things happen, funny things are said. And never feel like you can't laugh in an operating room. But as you first come into the operating room, you probably don't want to be the first one to laugh either, I guess I'd
I was
say.
gonna say, you need after we start breathing again.
After you start reading it again, and you realize that the tenor of the surgeon and everything, it's okay to have some fun with it too. So you want to be of good humor. Okay, so the phrase goes, be of good humor. It's always in good taste, as you said. Never at the expense of the patient, as I said. But it can really be invaluable as stress relief. Medicine can be very stressful. Some days more than others, but it can be very stressful, and humor can really have a healing quality to it for the people involved. And so don't feel like you can never laugh at something that's funny. But once again, you want to get to know your surgeon, get to know your RNs, your circulating nurses, whoever else is scrubbing in the case, get to know their demeanor about that because you don't want to offend anybody either. But for the most part, it's always good. So just tying up, professionalism is important. It's hard to define, but I think we all know what it is. I think you all knew what it was before I came here. Everybody kind of has a feel for what that really means to be professional. But sometimes it helps to get a few definitions. You want to respect the surgeon. You want to respect the RNs. And you want to respect all the other staff in there. And you want to expect respect for yourself as well. And you are going to be respected in the operating room, certainly in our hospital here. And above everything else, always hold the patient in the highest regard because that's what we're really there for. And it's always important to put that on the top of your list for your priorities for the day, because if you do that, if you really make a conscious effort to do at every step of the way what you think is best for the patients involved, everything else works out.
And what is that called?
Catering room.
Surgical conscience.
Surgical conscience.
That's exactly it. So this is what we don't want to have happen. How would you like to be that guy on that gurney, hearing all that? Not good. And the caption down there is chilling, but this is the reason why patients are going to be a little bit leery to begin with. Because people read that stuff in the media. They know medical mistakes happen. They know we're not perfect. They know we're not gods. Heaven knows we're not that. But when we have a system that's built with enough redundancies and enough checks and balances, then we can have essentially error-free medicine. At least as close to it as we can humanly come possible. So, questions or comments?
I have a couple of questions.
Okay.
One's kind of about professionalism. Like, what is one thing that you could tell us as scrubs that is something that you really like?
Or something you never do.
Yeah.
I mean, some black and white, obviously not going to go and sneeze on supplies or anything, but.
Other than the obvious.
Right, outside of the obvious.
Your ankle fingers, first step.
I mean, I personally am like really excited, but all that's intimidated by just the first scrubbing experience of.
Good questions. I love a positive learner, okay? Keep a positive attitude. One thing that I don't like, and I see this sometimes in new scrubs, is this self-chastising, auto-flagellating attitude of, oh my gosh, I'm sorry, I didn't know that already, I should have known that, you've already shown that to me once, I'm so sorry, doctor. No, I don't want that. I don't expect you to absorb everything like a sponge. You're learning a lot. And if it takes 2, 3, 4, 6, 8 times to get something down, that's okay. Don't whip yourself up about it. Don't beat yourself up in front of me. If you got to do that, go do it somewhere else. I don't want to hear you talking about how horrible you are that you didn't get that learned. Don't need to hear that. That's one thing I don't like. I like somebody who's a positive learner. I like questions. As I said, I like questions, particularly questions where it's clear that you're thinking about the process, or at least you're trying to learn about the process. You know, why is it that you do this before that? You know, that's good, as long as it's not something specific for that case that might alarm the patient. Like, now, why would you do that this time when you've never done that before? Don't say that with a patient awake in the room, okay? Because the answer to that might be something that has to do with a complication on the case. And that's not a good thing to talk about with a patient who's under the grade. Okay? The questions are good. Thoughtful questions are really good. And I don't mind, you know, just conversational questions either at appropriate times. And you have to be careful about those because you don't want to interject those at a time when there's something particularly intricate going on with the surgery. But, you know, I like just lifestyle questions too. Those are good. I mean, there are times when we're sitting there on a path case, I'm sorry, on a plastics case, and we've got the pathology off to the frozen section guy, and we're just sitting there for about 30 minutes with nothing to do, twiddling our thumbs. Gosh, let's have something to talk about, you know? Talk about movies or whatever. So, but it's a good question. Does that answer your question? Saw some other hands. Yes. You.
Me?
Yeah.
Okay. My question was like with all the different medical advancements, like the guns that will cut and clamp and suture all at the same time, like which one do you think has the best? Like which one do you think is the best? And which one's
What am I most excited about with advances? Well, you gotta understand I'm a little biased because I'm an eye surgeon. So my technology is going to be a little bit different than some of those other macro things. I'm a microsurgeon, but you know, I'm most excited about advances that are made in intraocular lens technology because you know, what I do as a cataract surgeon, and cataract surgery is probably 80 to 85% of what I do surgically. I mean, I do other things too, but most of what I do is cataract surgery. And that's basically the removal of the lens from the eye and replacement of a plastic lens implant inside the eye. And it's a great surgery, works very well, has very few complications these days, but there's an intrinsic limitation in the plastic lens implant that we put in the eye that it's a fixed focus lens implant. The lens of the eye, the natural lens of the human eye, for the first half of our life, essentially, is a very pliable living tissue lens that changes its focus with the constriction of the eye muscle in the eye. And that's how, when we're young, we're able to see at distance and see up close instantaneously, and it's wonderful, and then we get older and we need reading glasses and bifocals. You know, some people develop appendicitis as they get older, some people develop cholecystitis, some people develop coronary heart disease. Everybody develops presbyopia. It is an inevitability. And it's remarkably consistent over time how that happens with everybody. There's a table that everybody follows on losing their near vision. And I'm sure, you know, clearly there are some older people who can see up close, but that's only because they're nearsighted. They are losing range of focus at the same rate as everybody. They all lose it from birth to death. And it's a very fascinating principle. And someday, I hope that we'll have a truly accommodating lens implant that goes into the eye and does what the human lens did when we were young, which is changes its focus with the constriction of the muscle. And when we have that, we'll really have the holy grail of ophthalmology. We'll have something that will be done on people probably instead of LASIK, because they're going to need their lens out anyway eventually. We'll have it being done for just about everybody who can afford it anyway when they hit their 40s, so they don't have to wear reading glasses. So that's what I'm most interested in technologically. Are we there yet? No. Do I have some ideas about how it could work? Yes, I do. Can I tell you about them? No, because they're not patented, so I'd have to kill you. But that's what I'm most interested in technologically, is lens implant advances. Yes?
How would you say that you have developed your professionalism in the operating room over the years?
Excellent question. I've learned it from mentors, mostly. Not really something, honestly, you know, when I went through my residency program, which was in the late 80s, early 90s, I don't think that the ACGME had come out with this statement yet. This is a more recent statement than that. And professionalism wasn't really part of what was taught. And I can't honestly say that I ever had any book learning about professionalism. I had a lot of book learning about the science and even the art to some degree of medicine, but not about professionalism. So I learned that from my mentors, the people who trained me to do what I do, primarily in Texas, which is where I did my residency, but also from some other people that I would have been involved with before and after that. But you learn that from other people in your life too. I mean, I learned that from my parents, I guess. I mean, you learn the attributes of being professional and taking pride in what you do all through your life. And it's not just a suit that you put on when you go to work in the morning. It should be something that's an integral part of you as a person. And so I can't really say exactly where it came from, but I would say as far as operating room demeanor in particular, that would have been in my residency, and that would have been in Texas. From the people that taught me how to do what I did. I also learned their demeanor, I learned their professionalism, and that's how I learned to do it. And that's how I learned to to cope with things when they didn't go well. You know, I saw on the staff, I went to a place where we had 9 full-time staff, so I got to operate with a lot of different staff. I saw some staff that dealt with things very well when things didn't go well. I operated with some staff that didn't deal with things quite as well when they didn't go well. And I learned from that too. I learned what I didn't want to do. I learned how that could be deleterious to the whole atmosphere of the operating room. So mostly training, in operating room training, but not from a book. Nobody gave me this lecture. Yes?
Did you always know you wanted to specialize with eyes, or?
Not really.
I guess was there a
enough,
deciding factor that helped
there
you
were,
get there?
there were a lot of factors.
Yeah.
Ironically enough, the first surgery I ever saw was actually cataract surgery when I don't know if that was in late high school or if I was in early college. Back home working on the farm during a summer, I went down to Iola Hospital and watched some surgery. And Frank Bergeson, ophthalmologist in Emporia, was doing cataract surgery. That's the first surgery I ever saw. And it wasn't like I saw it and I thought, holy cow, I want to do that. No, it wasn't that at all, because it wasn't really that exciting to watch. I couldn't see anything. There wasn't, I think he was using a microscope, but there certainly wasn't a side port, and there certainly wasn't a camera. I couldn't really see what he was doing. It was kind of boring, actually. Got to see some, open laparotomies, and those were pretty interesting. Got to see some stuff I'd never seen before that way. But so I got introduced to it in that sense. I always have liked math and physics. In fact, I very nearly majored in physics, except I had no idea what I would do with it. And so I think that's why I gravitated toward ophthalmology. There's a lot of numbers, there's a lot of math in ophthalmology. We do a lot with measuring the eye and calculating lens implants, and there's a lot of scientific method with regard to that, so I like that. I like the mix of medical and surgical care. I love being a surgeon, but I wouldn't want to be in the OR every day. I like being a clinician, but I darn sure wouldn't want to be in the clinic every day. Those are brutal days. So I like being able to do both. I like working with elderly patients. I find elderly patients to be, for the most part, very understanding and have very realistic expectations, and very wise. Wisdom comes with age, and most of them have gained a lot of wisdom through their years. So I like working with elderly patients. You have to have some additional patience for working with them, but I enjoy working with them. So there's a lot of factors. Ophthalmology traditionally has been one of the hardest areas of medicine to get into, for one reason, because the call is better, and that's a draw. I get called a lot, but I don't have to go into CBER or any of them. I can usually walk the ER doctor through what to do, and I can end up seeing them in another day, or sometimes I have to see patients on a weekend. Sometimes I have to call in the OR team and sew up an eyeball on a weekend. You know, it happens, but it doesn't happen nearly as often that I have to do that as Rob McCullough has to come in and set up an OR on the weekend. So, you know, I like what I do for a lot of reasons. There are times when I've regretted going into medicine in general, not that many, but there's no time when I've regretted ophthalmology specifically. Yes?
I read that there's within ophthalmology, there's a lot of subspecialties, and I know you said that you work primarily in cataracts, but
I
do
do.
you do anything else with any other subspecialties?
I was fortunate to train where I trained, and then, as I mentioned, we had 9 full-time staff, and we had all the subspecialties covered there. In my residency program in Texas, it was Texas A&M, in my residency program, we really got to see some of everything from staff that was always there. We got to learn about all of it. Some residency programs, you don't get that. You just end up learning about, you know, 1 or 2 areas. So I was able to do a lot of retina. I was able to do a lot of cornea. I was able to do a lot of glaucoma. I was able to do a lot of peds. I was able to do a lot of plastics. And I was able to do a lot of comprehensive or you know, cataract, basically, based ophthalmology. And so that allowed me to do what I do here. Most ophthalmologists don't do what I do in 2013. Most ophthalmologists don't do as broad a brush stroke of ophthalmology as I get to do in Ottawa, Kansas, which is one of the reasons I love being here. I can do all those things. I don't do surgical retina. I don't bring retinal attachments into the operating room for buckles, you know. But I could. I was trained to do it. I don't do LASIK, but I could. I was trained to do it. I'm able to do, you know, a lot of the things that I choose not to do is just simply the logistics of I don't have time to do it, and I have people close enough that I can refer to. So I almost did a glaucoma fellowship. I was lined up to do one in Oklahoma. And then this opportunity to be in Ottawa came, and I realized, what's the point? I can do that already. I really don't need that fellowship training. It's an extra year. So I just ended up not doing it. So, but most ophthalmologists do fellowships now and do subspecialize into one particular area. And I'm really glad I don't do that. I like doing what I do. I get to do neuro-ophthalmology. Neuro-ophthalmology is not surgical, so it's not something you're going to see, but there's some of the neatest cases because it's more diagnostics and more head scratching, trying to figure that stuff out. And again, I wouldn't want to do that all the time, but they're kind of fun cases when they come in because you get to, it's one of the main areas where I get to really be a real physician. I hate to say that. I mean, but ophthalmologists are physicians, and if they're doing what they're supposed to do, they're integrating that into the general care of the patient, and it's fun to be able to call up the PCP and tell them, you know, hey, you need to see this patient because they've got a 6th cranial nerve palsy, and they don't have a particular reason why, and they're concerned about this, that, and the other, and really get involved with their general care. And we do that quite a lot in ophthalmology if you do it right. Yes?
I'm curious, as a surgical tech student and then a career, I'm interested to see how important our role is to you. Like how big do you
As a student or as an actual trained scrub in the operating room already there?
Like when we're done, like what
Critical.
does our role mean to you?
Critical. It's critical. Some ophthalmologists won't operate with anybody who's not their scrub. When I started, that's the way I was for a few years. I had Julie, who still works for me. That's from day one. She's now an RN, went through the RN program here, in fact. She was my scrub, and she's the only one who scrubbed with me in the places that I went, including Ottawa. And then it got to the place where she and I both realized I needed her in the office more than I needed her to scrub with me, and so I started scrubbing with the techs that were available in the various hospitals that I went to. And you know, my comfort level grew with that, and came to the place where I can cross scrubs without really any problem as long as they have their basic skill set. But it's critical, it's vital. I mean, that's kind of what I was talking about. Don't ever sell yourself short in your role in the operating room. It's incredibly important. It's not going to happen without you. I mean, it really isn't. You're a necessary cog in the wheel to provide the care that the patient needs. Does that answer your question?
Yeah, that's a good
Okay.
answer. I'm glad to hear it.
Yes.
Jennifer and I were talking yesterday. yesterday that as students or new scrub techs that, ophthalmology is one of the specialties that can be queasy at first.
Mhm.
Any recommendations on getting over it?
Exposure. Just exposure. That's it. You just have to see it. You know, I was telling you the story of when I was observing as a student and saw my first open laparotomy. I had to sit down. I didn't pass out. I had to sit down. Okay? And I grew up on a farm. I grew up seeing a lot of gross stuff. I'd never seen anybody's belly open up before. But then the next time I saw it, I was fine. My nephew, I have a nephew, Garrett Frank, who's actually, he's a physician, and he came and observed me. I think it was maybe before he started medical school, or maybe it was shortly after when he was just in the basic sciences of medical school. Came and observed me in the operating room, watched me do cataract surgery. He had to leave the OR. He had to leave the OR. And I remember him telling me afterwards, he was so embarrassed. I said, oh gosh, I guess I can never be an ophthalmologist. And I said, oh, don't worry about it. You'll get over it. Well, guess what? He's in the second year of ophthalmology residency now in Denver. Get over it. You'll get over it. Anything you see in the operating room that's going to make you uneasy, you will get over it. My oldest daughter had considered being a physician for a while, and then she decided not to. And the reason she told me was because she couldn't stand the gore of it, and I said, oh, there's lots of good reasons to not be a physician, but don't let that be the reason, because you'll get over that. You really will get over it. There's nobody who can't decondition themselves to seeing that. You see it over and over again, it's okay. As far as dealing with it at first, just be aware. Be aware that what you don't want to do is pass out and fall on the stair field. As long as you don't do that, it's all good. Just back off, sit down if you have to, leave the room if you have to. Next time you do it, it'll be easier. It's no big deal. Eyes do gross some people out though. Particularly when we used to do blocks. We used to do retrobulbar blocks. I would do them all. That's a 1.25 inch needle, 25 gauge needle with a blunt tip that you pop through the skin, and pop through the orbital septum. You can feel it, you can hear it, put it right behind the eyeball. I've had people hit the floor when I've done that before.
That is my concern.
But you know what, when you would do that, I would just turn around and busy myself with my own thing. It goes in here, and it's like hub, like the whole thing, it's like the
It
syringe
goes in the,
next to the face.
yeah. It's a little disconcerting for people to see. Yes?
A lot of us here, even though it's a 2-year program, a lot of us have devoted 3 or more years to, knocking out prerequisites, and in some cases prerequisites for prerequisites.
Sure.
And, so it's getting right down to it for us now, and in about a month we'll be at least in an operating room.
Exciting.
Yeah, and terrifying at the same time.
Sure.
So what advice would you give us for our very first day?
My advice to you for your very first day is to get a good night's sleep before, eat a good breakfast that morning. You don't want to do anything out of your ordinary, and just go in with an attitude to learn. Just, again, you don't want to go in there talking 90 miles a minute and asking a million questions, but you want to go in with an attitude to learn. You can learn so much from watching, you can learn so much from listening, and yes, you can ask very good questions that are appropriate. So, I think you're pretty fortunate to be where you are. I tell you, I've trained in some ORs, I've been in some ORs, particularly, when I was in medical school and in the operating rooms at KU Medical Center. There were some pretty malignant personalities in those operating rooms. I mean, I'll tell you what, I had some people that I had to work under that probably took years off my life just from how nasty they could be, for no reason other than just to be nasty. But there's nobody, I really don't think there's anybody in this hospital that's that way. I haven't seen it, I haven't heard about it. I don't tolerate that in my operating room. I know Dr. McCall is very good to work with. As far as I know, everybody else, even all the ones who come in from outside, treat people well. Treat people, follow the golden rule. Treat people the way you want to be treated. So my advice to you is just hold your head up high, be excited about it. You've worked hard to get to that place. You've earned it. Soak it all in. Ask a lot of good questions.
And don't pass out.
And if you pass out backwards. Stay on your heels, not on your toes if you're going to pass out, okay? Yes?
Okay, what's your favorite procedure that you've ever done?
Favorite procedure I've ever done? Maybe.
You remember the little girl that we thought she was gonna lose her eye? Do you remember that little girl?
I do, yeah.
That was like several surgeries that were really,
Oh, I know her well.
complicated.
I know her well. She comes and sits on my lap every time she comes in. Great kid. Yeah, those are probably the most rewarding procedures that I do, is when I take a kid who's had a seriously injured eye, a perforated eyeball, save their eye, rehabilitate their vision. So those cases that I've done are probably the most rewarding overall. I had a case just about 2 months ago or a month and a half ago where I actually made up a procedure. I know that sounds a little odd, and it wasn't a major procedure, but it was a lid case where I had a patient who had a very odd presentation of some lashes that were growing in the wrong direction. I basically just did a lid rotational procedure that I couldn't really find anywhere in the literature of what to do with it, so I just kind of made it up, and it worked beautifully. I mean, I just saw her back, in fact, just yesterday for her 6-week post-op check. It looks great. I'm gonna do it to her other side. Call it the Frank procedure. I don't know. But that sort of thing's kind of rewarding. You have to sometimes extrapolate what you know into new situations. As a physician, you want to practice evidence-based medicine. You want to do what's been proven and studied over time. But there are times when there isn't anything that's going to work, and you have to get outside the box a little bit. So that category in general is what rewards me the most. Is when I get to really create something on my own. It's interesting. I feel like I'm two kinds of surgeons. I'm an analytical technical surgeon when I do cataract surgery and everything's extremely precise. And then when I get to do plastics cases, I get to be an artist. It's like I'm using the other half of my brain. And because it's very different surgery. It's really an art to take somebody's eyelids and remove half of it and reconstruct it in a way that's going to be aesthetically pleasing to them. And that's rewarding. But again, would I want to do just one of those all the time? No, I like to do both. I like the mix. Yes.
Kelly was telling us a story the other day, and we've been learning about sutures, and I don't remember what you were passing, what you said that you were passing. And you loaded it correctly, like if it was just a suture or?
oh no, it was just a tie, it was a tie on a passer.
Tie on pass, and she
You
loaded
can't
it.
really load wrong.
Yeah, so she loaded it correctly, and the surgeon threw it back. So she loaded it correctly again, surgeon threw it back. So she tried it the other way, he threw it back. So then she went back to the first time, and he ended up taking it. In a position like that, where
Tell me that wasn't me, Kelly.
so my question is, in a position like that, where you think or you know that you're doing your job correctly, but the surgeon thinks that you're not.
That's an excellent question.
What
do you do?
Yeah, what would
do
you
you do?
advise?
Well, I'll tell you what, again, you have to kind of know the personality of your surgeon and how well you know him. I mean, I think most of the scrubs that I work with, who've worked with me enough, would be comfortable enough to say, Doctor, I think I've got it right. And I'll take a second look at it and see why it's not looking right to me. But there are some surgeons that may not be comfortable with that. I think the way that she did it was probably correct. Second time, do it the way you think it should be again. Maybe somehow it wasn't quite right, or he just looked at it wrong, or she just looked at it wrong. If they reject it again, third time, you better try something different, but you might say something like, I'm not sure what I'm doing wrong, doctor, can you help me? Because maybe there's some nuance that you're not aware of, and you think you're doing it right, or maybe you do have it exactly right, and when he gets to examining it and trying to instruct you, he or she will realize, oh, wait a minute, That was right. So I think the way she handled it was probably about the best way you could.
Okay, so in addition to that, if you're in a surgery that you have to do it the right way, I mean, it's not just something that they can necessarily fix themselves, like adjusting a suture or something. And you have a cantankerous surgeon that is not playing well with others, or, you know, what is going to be, I mean, if you can imagine yourself in that position, which you obviously don't seem like that type of surgeon, but what is the least damaging way that you can say, I'm really not sure, you know, how you want this or how this needs to be without undermining our competence or, you know, their confidence in our abilities? Maybe it's just something new you hadn't seen before. What is it?
Yeah, I think most surgeons, even ones that are not the nicest of people, are going to want to be a teacher in some fashion. So I think maybe the best way to approach it would be to say something like, can you please teach me how to do this better? Can you please instruct me in how I can do this better? Is that the scenario you're talking about?
Yeah, basically.
Basically kind of knowing what to say.
Yeah, without it coming across as just, I don't know. I mean, you know,
Right.
it's not make yourself sound stupid necessarily, but.
Well, and you can say, you know, this is the way I've learned it, but please help show me how you like it done. You know, that might be a good way of putting it, because that shows that you feel like you know what you're doing. It's not like you're clueless, but you're understanding that maybe your way of learning, that you've learned it, isn't the way that they want it. And you're happy to change. So I think that's probably the best way of phrasing it. Yes?
If you had to choose like a completely different specialty, what's one you think you'd enjoy?
Good question, and I can answer it very easily. Orthopedics. When I was deciding what I wanted to do, it came down to ophthalmology and orthopedics. Love them both. And they may sound very different to you, but they're really not. They're both very mechanical. Again, I like the number stuff in ophthalmology, but I love working on stuff, and you know, orthopedics is really working on stuff. And ophthalmology is too, it's just on a much smaller scale. They're both very mechanical. So in deciding which one I wanted to do, I asked the residents at KU what they liked the least about their specialties, because I knew what I liked the most. And the orthopedists told me that it was back pain. They hated dealing with back pain. Operate on it, half the time gets better, half the time gets worse, can't fix it, patients are unhappy, end up with a lot of drug-seeking patients. They hated dealing with back pain patients. The ophthalmology residents told me that they hated dealing with glasses problems. Patients complain about their glasses, they can't see with them, they don't like them, you know, they want a new pair, blah, blah, blah. And I just decided, no, of those two things, I think I'd rather deal with glasses problems than back pain. So that's honestly what made my ultimate decision. I mean, on a bad day, yeah, I get a lot of glasses complaints, but okay, we can fix it. Ultimately, we can fix it. Can't necessarily do that with back pain. Yes?
What is the most professional thing you've ever had a scrub do?
I don't know, but I'm sure it was Kelly that did it. Or maybe Jen. It could have been Jen too. Either one. But what impresses me most, and I alluded to it in the slides there, what impresses me most is when they will do or say something that they don't have to, that I know is in the patient's best interest. In other words, let's just say that they happen to see that there's a hole in my glove, or that they happen to realize that they've contaminated something, and they were the only one that saw it, and they could have just, nobody saw that, I'm just going to go ahead and go on. No, big red flag. Don't ever let yourself do that. You know, when I see somebody who said, oh, I just did this, I'm going to have to break out the whole set, doctor, I'm sorry, and they know that that's going to take an extra 10 minutes, and they know that's going to put us behind, but they did it because it was the right thing to do, because of surgical conscience, like she talked about, that impresses me. That's very professional. I mean, if you really think about it, if everybody in the world would just do what they thought was the right thing to do, even if they can get away with the wrong thing to do, we'd have a wonderful world. And so anytime anybody does something where I can see that they really care more about the patient than they do about the time in the OR or what people think of them, that is professional. That's the most professional thing I can think of that a tech would do. And that's what you can live with yourself best at the end of the day with too. You know, you don't have to look back in the day and say, man, I should have told somebody about that. Yeah. Just pipe up.
Kelly put you up to that, didn't she?
She did. But I know the cloth she's cut from, so I'm not surprised she's told you that. It's something you haven't heard already, I'm sure. Anything else? Okay.
Thank you very much for
Sure.
listening.
Hope it was enjoyable.